Good evening, everyone, and welcome to tonight's webinar. My name is Eric Hughes. I'm a product manager for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't see or hear you, but we would love to hear from you and be able to answer any questions that you have that come up during this webinar. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we will try to get to as many as we can during the end of the webinar at the Q&A section. Now to introduce our presenter tonight, Dr. Tamir Wardany is a board-certified oral implantologist and diplomat of the American Board of Oral Implantology. His referral-based practice is uniquely limited to hard and soft tissue augmentation for the preparation and management of dental implant treatment. He also shares his time as a surgical specialist with Capital Periodontal Group in Sacramento. With over 20 years of experience, Dr. Wardany is focused on advanced training, clinical practice, and research related to implant surgery and regenerative procedures. After earning his dental degree from Meharry Medical College in Nashville, Tennessee, and completing an implant residency, he continued with extensive training in Europe alongside leading experts in implant and bone augmentation surgery. Dr. Wardany conducts clinical research with his practice and has collaborated with the Department of Reconstructive Surgery at Stanford University on studies related to bone regeneration and implant biology. He lectures nationally and internationally on the topic of bone regeneration as it relates to implant site development. And most recently, he lectured at our bone grafting symposium out in Phoenix. And with that, I will let Dr. Wardany take it away.
Hello. Happy Thursday afternoon, evening on the East Coast. My name is Dr. Tamir Wardany. I'm a surgical oral implantologist out here in Sacramento, California. And I want to thank Osteogenics for having me on this webinar tonight. It's a great honor to lecture for such an awesome regen company that provides so much support and so many great products for the type of bone and soft tissue regeneration that I specialize in. So I want to thank you all for being on tonight, taking some time out of your evening to do this webinar with us. You know, this is a very special webinar for me. This is a topic I presented a couple of weeks ago at the great Osteogenics Bone Grafting Symposium, and it was just so well received and such a very applicable topic, alveolar ridge preservation, decision tree, and considerations. So, you know, I want to start and just go right into it, and hopefully I'll have time for some questions at the end of this. So, you know, I like to start by showing a case here of a resorbed ridge. Severely resorbed ridge is horizontal resorption that we have that you can tell we've already started doing some bone decortications here to start the process of guided bone regeneration to merge biology with the biomaterials to see what we can get. I have a technique that I use. I call the bone net. It's a offshoot of a Italian study that was done about 6 years ago on edentulous arches. And we made some modifications using this TXT PTFE membrane, able to give us that apical support of the particulate bone material that we use to really have the support to condense the bone to get that horizontal ridge volume. You see how we're condensing that. We've done this in so many cases now over the last 5 years, about at least 150 cases. We've used this horizontal technique. And what we end up getting, we put a native collagen membrane over it. We keep the PTFE apically at the buccal aspect so that we don't deal with the exposures that we know we have challenges with at time. And then when we come back in and we look at a CBCT immediately after placing the bone, we can tell that that apical fixation gives us this incredible bone condensing result. You see there on the bottom where that bone looks so nicely condensed, so nicely formed, giving us that beautiful contour that I know is going to last during that 6 months of healing. And so when we come back in now at 6 months, doing these guided bone regenerations, and there's so many techniques out there for everything we're going to talk about. Guided bone regeneration, alveolar ridge preservation, so many techniques out there that can be used. But when we use techniques that are biologically and technically sound, we go back in and we just get these gorgeous results and just we can be so proud that our implants are going to go into this wonderful foundation. You can see the results here we get. You can see the large augmentation results we get. And we do this over and over, horizontal, vertical augmentations. We have our technique for that. And this is really what my passion is for, is using biology to be able to gain these wonderful, larger ridge augmentation results. Here's my information on the screen here. This is my office right now. You're looking at the picture where I'm at right now. I have my office, and I also share my time at a periodontal group here in Sacramento, Capital Periodontal Group. So, if my partners are watching, thanks for being on the call as well. So I really have gone from a place of being a general dentist and then transitioning to a surgical realm and just focusing so much on creating ideal foundations. My practice specializes in large augmentations, sinus augmentations, implant revisions, and the peri-implantitis grafting. There's my information. I'll hopefully put it up at the end for anybody watching here today. But I start with that large augmentation with the big caveat that really, it's Thursday, it's the end of my work week here. I'm going to come back in Monday morning, and most likely I'm going to have this type of situation on my schedule. It's probably not going to be first and foremost a vertical augmentation or a large horizontal augmentation on Monday morning. Most likely I'm going to start off with the bread and butter of what we do. No matter what type of surgical practice I have, no matter how many large augmentations I get, I can almost bet my bottom dollar that most likely I'm going to have some kind of post-extraction socket to manage. And so when we look at this socket, we see the bundle bone, we see the root gone, the PDL has been severed. This is about to go through a transformation here. So whenever I start speaking about ridge preservation, I think we've gone past the time, and osteogenics customers are typically high-level grafting surgical customers, where I think we can get past the wonderful age-old Araujo and Lindy studies back from 2005, 2009, where we discussed a rationale for ridge preservation, where we discussed bone resorption in the first 6 to 8 weeks following extraction. I think now we know that there's going to be a degree of bone resorption that occurs with or even without or even with ridge preservation, I should say. There's going to be a degree of bone resorption. And I should also say that we know that there has been documented a rationale for ridge preservation and putting bone in to preserve the ridge and what we like to call socket grafting. So I want to get past that. When I give a ridge preservation lecture now over a 45-minute webinar, I like to step past that. This is not a how-to. This is not just a quick how-to. I want to get past that and go into what are the variations that we see with ridge preservation. So my topic really centers around a 5-year in-office retrospective study that we did. I do quite a bit of in-office data and research for my office and for my lectures, where we collect the studies over the past 5, 10, 12 years that I've been in practice here to really figure out what techniques work, what biology work, what are the complications that we run into. I always tell newer students that I have that, if you don't have complications, you're not doing surgery. So I like to really thrive off of the complications that I have and learn from the mistakes that I've made. So, when it came to ridge preservation on the surface, they say, this is basic. We're just filling a socket here. There's really not much to this. But when I really took a step back and looked at the 5-year studies of about 483 cases, we wanted to look at what were the unexpected negative variations that came about. What were the things that made us say, that happened? Why did that happen? What is going on there? How can we analyze an approach to avoid that sort of situation? So that's what I want to discuss today. Is I want to get into the nitty-gritty details of this study and what we found, so that I can guide you on how you can make ridge preservation something so simplistic even more predictable, so that you can watch out for the pitfalls that you may see. We know that when we talk about ridge preservation, we are talking about an external dimension. And if you look at this graft here, this was a case that we did ridge preservation grafting on at the time of extraction. And what we see here is absolutely gorgeous bone. There's absolutely nothing wrong with this bone structure here. The bone integrated very well. Clearly, the osteoblastic biology worked great. But when we take a look at what we see here after about 4 months, we still, even with a gorgeous graft, we still have a degree of external resorption. And we know we see this more so in the anterior, especially in those anteriors with more of a thin facial labial plate. So we look at the external dimensions of these grafts. Now, beyond the external dimension, we're also going to look at the internal volume and the quality of the bone we get. Now, this is going to be usually more significant in the molar region, where we have such a wide socket base. And with that wide base, there's a long way for those osteoblasts and that activity to travel towards the middle of the socket. So with the molar space, we're concerned a little bit less about resorption because we're going into it with such a large and robust buccal plate. But we are more concerned about reopening the site and getting in and seeing this kind of crappy, soft bone quality that we, every now and then we get in there, we see it. And maybe it's just in my practice, but it's something that I see every now and then. You open up and you just get a little more soft bone, which is not a fun thing to see when Mrs. Smith has been waiting for this implant for so long. 4 months isn't a long time to us, 5 months, but for the patient, that is quite a long time. So when we go back in and we see this internal bone quality, we can be a bit concerned. So we're looking at an external dimension and an internal bone quality. I do a lot of guided bone regeneration. Guided bone regeneration is predicated on having a blood flow, a bone osteoblast, as well as soft tissue isolation. When we keep using the term alveolar ridge preservation for a socket graft, I'm in a mindset shift, a paradigm shift right now, where really a root came out. I'm not preserving anything because I know there's still going to be dimensional changes. There's still going to be internal and dimensional changes. And I know there wasn't a bone in there to begin with, so I'm really not preserving any internal bone that was there before. So I like to say a better term for alveolar ridge preservation is really better to be said as guided bone formation. We are still, for the most part, and I know there's other techniques out there. Don't get me wrong. I'm a traditionalist. But we know we're using a membrane. We know we're using bone. We know we're using a blood supply. So in terms of what I like to call this guided bone formation. We're forming new bone where there wasn't bone previously. So briefly here, I'm going to go through the key biomaterial players for the study that we've done here. And really, I defer. I'm not going to go into a whole large array of all the different bone substitutes out there, just really what we used for this basic study here, looking back at our cases, trying to keep it pretty uniform throughout the study. So I defer to Brian Mealy, UT San Antonio. He and his group at the department there, periodontology, have done just excellent studies on the types of bone used and which allografts yield, or even which xenografts, but really they focused on allografts and which ones yielded the best vital bone. And really that's what's important, is not just getting bone. I can use any bone substitute and get some hard bone, but I want vital bone that's really going to have blood flow and vasculature through it to be able to create a healthy osseointegration for that future implant. And what he and his group found was that the demineralized allograft was probably the graft material that yielded the most vital bone of all the options out there. But we know when we use a demineralized material, we take an x-ray and you look at your assistant and say, where'd my bone go? Well, we don't want that. We don't want to see nothing on the x-ray. And I think Mealy and his group knew that. So really a graft of choice is a 70-30, 70% mineralized, 30% demineralized bone allograft that we use. Encore bone through osteogenics is what I use for my grafts. And using that bone has been shown through the histologic research of the Mealy group at UT San Antonio to probably yield the best amount of vital bone in my grafts. So that's the bone substitute we're using for this study. You can see us packing this bone here. I'm sorry, I'm going to go back here, just one step here. Now, what membranes are we going to use here? What are the membrane choices? Now, obviously, there's, again, many different membrane choices we can use, and there's some techniques that don't use a membrane at all. There's some techniques that use just a PRF membrane at the crest there. But again, I'm going the route that's worked for me for quite a long time, and it's worked very successfully. So I'm going to stick between a DPTFE membrane, a non-absorbable membrane, or a collagen matrix, okay? A collagen matrix is going to be a collagen scaffold for those adjacent epithelial cells to use as a scaffold to grow into the space. So when we talk about the non-absorbable DPTFE membrane, the benefit of this is that it's really going to be an excellent space maintainer. It's great for larger sockets. And I will say I use it for larger sockets most of the time. For video purposes, I'm showing an anterior socket here, but I use it for anterior as well. Anytime I have a defect, anytime I have some kind of dehiscence or fenestration, this is really my go-to. When I'm trying to protect the bone, we know that at the crest, we were looking for that secondary epithelialization. We are looking for the crestal epithelial tissue to grow over the crest and create a nice tissue layer. Well, when we use this PTFE, we're going to delay that secondary epithelialization. We're going to focus on space maintenance, protecting the bone, creating space for the osteoblastic process to take place before we have that secondary epithelialization process go. You can see I tuck it here. I usually like to tuck it on the lingual or the palatal first, then pack my bone. It just makes it easier to manipulate. And then once I'm done with that, I make a very easy sulcular space, their little envelope space, and I'll tuck it in the buccal or the labial. If this is done right, these sutures that you see me placing really aren't doing too much. The sutures basically are so if it does come loose, the membrane comes loose, Mrs. Smith on the weekend doesn't give me a call and say, my cousin's cousin, who's a hygienist, said you should have sutured, doc. Well, I don't really want to be in that position on the weekend, so I put these sutures just for safekeeping. But really, if that PTFE is tucked correctly, then this membrane should not be going anywhere. Now, that can be a little different when we take care of some sockets with defects, like you're going to see a bit later here. But we come back in 3, 4, 5 weeks. This has to come out. This cannot stay in indefinitely. We take that out. We do not need to get primary closure over the PTFE in a socket grafting situation, which is a bit different than we do a larger augmentation. But you can see once that PTFE comes out, we've got this immature granulation tissue, immature connective tissue layer. Now, once that membrane comes out, that secondary epithelialization process will start to take form. I find that PTFE has some magical qualities. When PTFE is done correctly, and we know that in larger augmentations, we have to manage it and address it correctly so that we don't get any complications. But when we get great PTFE outcomes, you can see the bone we get. We come back in 6, 7 months on these larger augmentations. One image I like to show just to reinforce how great PTFE is as soft tissue barriers, a soft tissue isolator. This was one of our first techniques we did with our bone net. And you can see we do that PTFE in, and don't poke holes through it like that. That was just an experiment we did, but no, that's off label. But we did this PTFE apically here at the buccal, and then you can see it was cut a little short. So we put some native collagen membrane to double layer it right towards the mesial there. But what was really telling to us is when we came back in 6 months to reopen this case, this was our very first case testing out this technique. Look at the area where the PTFE was. You can see the exact delineation of where the PTFE is versus where the collagen double layer membrane is. So you can see the power of PTFE, I like to call it. It's just an awesome way to create a soft tissue barrier until we want to have that soft tissue start forming. Now, with the collagen matrix, I use this more in the anterior zone, smaller sockets where there's no defects, no bone defects. I'm just looking to get great soft tissue formation over the crest. Now, this is going to be resorbable. It's going to allow for cell migration and cell formation across the collagen. So it, just like we tell patients with a particulate graft, the graft acts as a scaffold for the osteoblastic cells to crawl into the graft. That's how we explain it to patients. Well, in an epithelial realm, in a soft tissue realm, it's doing the same thing here. That collagen matrix is acting as a scaffold. This is what we call Z-derm by osteogenics, and it's just a great collagen matrix here. The cells are going to grow onto this, and we see the fast epithelialization. In these cases with the collagen matrix, the secondary epithelialization starts the second the case is done. It starts immediately, different than that PTFE where it's more of a delayed epithelialization process. But look at 14 days post-op. Look at that soft tissue almost completely closing over the crest and just growing in just beautiful keratinized tissue there as well. So this is nice. It doesn't have to be removed. It's going to resorb on its own. I usually use some resorbable glycolon sutures when I'm suturing this down into place, and we just get some really nice results here. I always tend to remind surgeons to not skip this step. By taking a diamond burr and de-epithelializing the margins, you're stimulating an accelerated secondary epithelialization. This is almost akin to when we are doing that ridge augmentation and we poke holes or we decorticate the ridge to get the growth factors out from the internal ridge. This is almost the same exact process, just in soft tissue form. So I call this a lost art because people just don't do it much anymore. It's not taught as much anymore, but this is such quick healing. This image here is about 10 days post-op, and we just get such quicker secondary epithelialization when we do this. And this in particular, I do with that collagen matrix, that Z-derm. So now that we know what we're playing with fairly healthy patients in this study. So I filtered out the patients who are diabetics, the smokers, the SSRI patients, even the penallergic patients. I stuck with fairly healthy ASA1, ASA2 patients. I'm using a 70-30 allograft encore for all these cases, or for most of these cases, I should say. I'm using either a PTFE or a collagen matrix in the indications that I just went over. So where did things go a little awry? What did we learn from this study? Where did the ridge preservation deviate? Well, I want to start here in the anterior zone. On the anterior zone was where really we see our first consideration that really stood out to us. And in the anterior zone, it's the one area in the mouth where I probably do the least amount of ridge preservation. And why do I do the least amount of ridge preservation there? Because we have other options in the anterior zone. But when I have a patient who may be very young, maybe it's a very young patient, maybe it's a medically compromised patient, maybe it's a patient that is unsure whether they're going to be placing implants at all. Maybe they just want some bone in because they're planning on doing an implant, but they can't afford it now. They're going to do it later, or they're just not sure they want it at all, or they're just not a good candidate right now, in my opinion. Then in the anterior region, that's where, and there's a few other factors, I'm sure, that fall into that category, but that's really the reasons that I would do ridge preservation in the anterior. But the anterior gives me other options. I can go extract a tooth, place a bone graft here. But what do we tend to see? Sometimes we get a situation where we don't have enough bone volume for ridge preservation, for the implant placement, or we've gotten enough bone volume, but we've had some resorption, I should say, creating a zone where I have to go back in and do an added contour augmentation. And that's really what we found here in these cases, is that a lot of cases where we did ridge preservation grafting in the anterior, about 68% of these cases, and that seems like a high number, but if I'm being a responsible surgeon and I'm making sure that there's enough bone volume around the implant, then yeah, if I go in and this is what I see right here, if this is what I have, that's not responsible to leave that in there. You can see I've already decorticated this site here, but had there been no decortication here, you would see a thin labial bone plate that is not enough. That labial bone plate is really going to disappear over 3, 4, 5 years. So we saw that 68% of these cases needed a second stage contour augmentation, not preservation, contour augmentation to add bone. So what we did was we took autogenous bone from the ramus here. Always put autogenous bone on my contour augmentations. I layer it in a very Danny Boozer philosophy out of Switzerland there. I will layer a xenograft over this, and then we'll put a native collagen membrane here, suture that down, and we can get great results with that. But do we want to be in a position to do that all the time? Well, the problem with the anterior is that what we get at the time of extraction is not necessarily the final condition we are addressing because of that resorptive process that's going to occur from 6 to 8 weeks post-extraction. When we're dealing with the anterior, I like to say it's almost like we're jumping on a moving wave. We don't really know where we're going exactly. Things aren't fixed. We're jumping on a moving wave. We're trying to get on at exactly the right time so that we don't get crushed under that wave. So my guideline for the anterior with ridge preservation grafting is that when I graft a site, if I have a site that is facial palatal at or less than 6.5 millimeters in dimension, I'm a little concerned because at some point I'm going to get resorption. No matter what, I'm going to get a little resorption from that healing of that graft. I'm going to place the implant. Maybe it's a 3.3, a 3.5 implant. Now I only have about 2 millimeters left of a buffer zone. Well, what if I place that implant just a touch more facial than I wanted? Even if I use a guided surgery, I can place maybe a little half a millimeter, a millimeter in the direction I don't want it to go. It happens sometimes. Well, now I'm left with maybe a millimeter of bone left. That's really not sufficient for me to be in that situation. So in these situations, if I know I'm going to need a little more, I'll either plan for the contour augmentation or I'll do a little socket augmentation at the time of grafting, at the time of extraction. I'll make sure I augment a little bit towards the facial at the time of extraction. So what other options do we have at the time of extraction? We can obviously go immediate implant placement. Obviously, this is a technique that's been well documented, very successful technique when we have the proper parameters. And you can see just a basic technique here. I'm not lecturing on immediate implant dentistry right now, but basic technique. We extract the tooth, we place the implant, we place the scan body here. I like to scan at the time of implant placement. It helps me to do a provisional at about 6 to 8 weeks later. I don't do a lot of immediate provisionalization, but there are times where it's indicated. But for the most part, I usually scan and place the provisional in about 6 to 8 weeks to start contouring the papilla. We close up here. This is a PTFE membrane in this case. Close up with a PTFE suture, and we can get some beautiful results on these cases. Just gorgeous tissue, gorgeous results. Well, that can obviously repeat itself, hopefully. Take out the tooth, place the implant. Again, bone in the gap. Put some xenograft. I tend to put xenograft in the gap on these cases. You see the sutures here with that PTFE membrane, and we've got another immediate implant in place. I want to make note here that the implant on the left, number 9, was done about 3 years prior. Same implant. We were using a little wider diameter implants back then when this case was. But I want you to take note of this implant. So we placed another implant. It's been crowned by the restorative dentist. And then we came back and we look at this 5-year follow-up on number 9. So number 8 is still at about 2 years. Number 9 is now at 5 years. And look, you can see the threads of the implant. You can see a little mid-facial recession starting. The thinning of that labial bone is occurring. And that's what is very known in immediate implant dentistry when we don't follow the proper guidelines, the proper parameters that have been laid out by researchers like Boozer and Chen over and over and over. This was a study done back in 2014 showing that if you do not follow the main guidelines, those guidelines are first and foremost making sure that the labial plate is more than 1 millimeter thick. It's got to be more than 1 millimeter thick. 1 millimeter or less is not enough. Soft tissue should be thick. Really, there are so many other criteria that I'm not going to get into just for time today. But if we don't follow the criteria that's been laid out for immediate implants, and I think it's funny sometimes, surgeons, colleagues of mine say, oh yeah, I place almost every implant immediately now in the anterior. Well, if you look at the CBCT studies on labial facial bone thickness, the studies show that most labial or facial plates are under 1 millimeter in thickness. So how is it that so many surgeons are placing immediate implants most of the time in the anterior when most labial plates are thinner than 1 millimeter? Unless everybody is augmenting at the time of immediate implant, which I don't think is what's going on, this is what you see. You can see how the studies show that over 4 or 5 years, mid-facial recession, facial bone remodeling, thin bone is very prevalent here. So I'm a big believer, and what we have really studied in our office is trying to mitigate against any chance of issues with that. I try to be as conservative as possible, but also as predictable as possible. So I love early implant placement because that truly predicts the biology. It tells us that we are predicting that there's going to be a degree of facial plate resorption. We know that resorption is coming, and it allows us to plan and hop on that wave at the perfect time. So you can see we extract a tooth and then we get back in. 6 weeks, I've done basically a non-CTG, I like to call it, where the body has basically done the connective tissue graft for me. It's thickened the soft tissue just by virtue of healing into that space. And we get this beautiful soft tissue at 6 weeks. I usually like to go in right at 6 weeks. You can see the defect here. You can see the resorption that's happened here at 6 weeks. We get back in. I like on these cases, I harvest bone. I can do a very conservative bone harvesting at the lower ramus. I make a small incision with a 15C, I don't even go sulcular on this, very small vertical incision. Push it back with an Urban Mini-Me here and just reflect the flap here very conservatively. If I'm working in the anterior, especially on a single tooth, I don't need that much bone. I just want some autogenous bone to help my graft out. I wanted to layer that graft. So we take a micros scraper. I don't take a large safe scraper on these cases, just a thin micros scraper. I get the amount of bone I want. Now we're going to layer that bone facial to the implant. I always do a layering of the autogenous bone first, followed by the xenograft. And we're going to continue to layer more and more xenograft in this case. So thin layer of autogenous bone in this case, large layer of xenograft. I don't show the whole large layer here, but you can see the effect of that layer in this image here. So we get this large layer of xenograft, but I always use a native collagen membrane in these cases. I like to suture the membrane down. We do hands-on courses where we teach the suturing of the membrane in these cases. And then we close up. Now, in these anterior cases, when I'm doing an early implant placement or even a contour augmentation, in these cases, I don't necessarily need to get primary closure. I put that native collagen membrane. I like to put just a TXT, a PTFE, DPTFE membrane. It can stay a little bit exposed. I actually prefer it to stay a little bit exposed. So again, I can go in at about 4 or 5 weeks, take it out. You can see what we got here, this immature granulation tissue, but we get just such beautiful bone volume from these cases. And when I go back in from the post-suture CBCT to the 5-year, you can see that excellent remodeling and that excellent maintenance of the autogenous with the xenograft. But had I just done a simple immediate implant on this case, I'd either have deficient bone or just hanging by a thread facial bone. So consider early implant placement. We went ahead and looked at a study. Sorry about the alignment here on this study, but we did a 2-year study and looked at 116 cases. And what we found was that we had much more horizontal bone volume around the early implant placement cases than we did on the immediate implant cases. It was quite a stark difference between the two. If you have the parameters for immediate implant, go for it. Or if you don't, then you better consider augmentation at the same time of your immediate implant. But if you're going to have an augmentation, and it's going to need quite a bit of work, consider early implant placement in those cases. Now, we're going to transition now from the anterior. We're going to start going to the posterior. Well, what about in the mandibular molars? What could possibly go wrong in the mandibular molars? What things did we see there that deviated in these cases? Well, I'm going to go over it briefly here. When you extract a tooth here, sometimes you look down and you see nothing left. You see no more interradicular bone here. That interradicular bone, that bone that separates the mesial and distal roots, is gone. Maybe it was a difficult extraction. Maybe you had to do a lot of drilling to get the root out, and you just iatrogenically took out that interradicular bone. It can happen. Well, what we found was that in cases where we lost the interradicular bone, we started seeing results like this. Take the tooth out, and this is a case where the biology had taken away the interradicular bone, not my removal of the roots, but we've got just a wide bone socket that is strictly an allograft in there. And we started seeing just not so great implant healing on these cases, or an uptick in implant complications. We went back and we looked at now 103 sockets. And these 103 sockets were all cases that in my notes, I documented that I took out the interradicular bone, or I could see it on the x-ray that we removed the interradicular bone. What we found was that when there was interradicular bone, in 70 sockets with the interradicular bone, we had normal, predictable healing, excellent bone quality when we went back in, and just great implant results. But in 5 out of 33 cases, the 33 cases where we did not have that interradicular bone, we had that uptick in complications. And what I realized, and not to be arrogant here or anything I like to say, but when I do my larger augmentations, I rarely have failures of those implants. I do not get a lot of failures when I put implants in after a very large augmentation. And what we realized was that part of this implant is going into native bone, and most of the time the buccal bone volume is strictly a veneer or contour augmentation buccal to those implants. Well, this coincided with a great Korean study done back in 2017, and this study confirmed that when you have primary bone engagement, they called it PBE. PBE is part of the implant is in the native bone. when you have primary bone engagement, that could be at the lingual, at the mesial, at the distal, at the apical. When you have that primary bone engagement, you're going to get a higher rate of implant success. The less amount of primary bone engagement where the implant is 360 degrees surrounded with a graft material, that's going to be a higher rate of implant complications. So what we like to do with our cases, we like to try our best to maintain that intraradicular bone. By maintaining the intraradicular bone, it's almost like we're grafting two very small sockets, allowing the walls of the bone to just integrate in a very narrow space to create that osteoblastic transition from soft to hard bone there. So really try to maintain that intraradicular bone. These are just tips and pearls. And I like to say, if you're going to take bone away to get the root out, I would almost rather go out the buccal because it's much easier to manage a defect. I've got a great method I use to manage defects, and I just want to pause here and go through a brief defect management tangent. But when I have a defect management, this is one of the techniques I use that is 100 out of 100 times successful. I don't use cross-linked membranes too much, but with this method of managing a defect, I use the RTM cross-linked collagen membrane from Osteogenics. I love this membrane for managing a defect. And what I do is I cut this membrane into a rectangle. I place it apical to extend the defect 3 millimeters each way and submerge that. It's not going to go over the crest. And then I'll transition into a normal ridge preservation where I place a PTFE membrane. You can see the PTFE membrane on the outside, the cross-linked collagen membrane right up against the bone, right up against the defect. I want you to extend the cross-linked membrane 3 millimeters each way. The PTFE membrane, you can see I cut it like a teardrop, so it is wide at the base, but it doesn't necessarily have to be 3 millimeters each direction. And then I close up with open healing, just like I would a socket graft. You can see a little video here showing we've got a defect underneath there. In this case, I'm placing the PTFE first. It doesn't matter which one you place first, just make sure the cross-linked membrane is what's going to be up against the bone surface, because again, this PTFE is still going to come out in 4 to 5 weeks. We can see the RTM cross-linked membrane going in to line that defect we have there at the mesial. It's going to line it 3 millimeters mesial, 3 millimeters distal. And now we're going to go ahead. In these cases, when I have a defect, especially in a large socket, I like to add some kind of growth factor. I can use a PDGF. I can use that sort of growth factor, but I can also, which is much less expensive, I can use some autogenous bone, which does miraculous things for a graft. You don't always have to lay a large flap to take autogenous bone. Sometimes we just make a small incision distal to the site so we don't reflect the flap at the socket, at the crest there. Make a small flap. I start tunneling. Again, this is a Hugh Freedy mini-me, and we're just making a little tunnel space there to access the bone. And for these especially, I will use the thinner micros scraper to now go into that small tunnel we've created and harvest some autogenous bone to mix with that allograft. I have a large socket, I've got a defect. Yes, sometimes I want some kind of growth factor to activate this graft and turn it on. Always get the question, could you use PRF? Sure, you could use PRF, but that's not nearly as much of a growth factor capability as autogenous bone or a PDGF if you go down that road. So this is a great conservative technique to just tunnel in, get that micros scraper in there, and get some autogenous bone graft in your socket with the allograft. And you can see that's mixed in. We've got the socket covered there. Now, when we come back, I want you first to note on the left, excellent soft tissue here. Look at that keratinized tissue. From what we started with to now, we get miraculous results with those membrane, that combination of those two membranes, just great keratinized tissue. But really, look at the bone here. Look at the great bone volume we have. And what we've learned, we would think that buccal defect, even if it's a large defect, we would think that's going to take a long time to heal. But really what we've learned is that periosteum communication directly up against that buccal plate creates a much faster healing of that cortical plate, not to mention the approximation of the cortical defect and the bone together. When you go back in 5 months, 6 months sometimes, or even 4 months, you will add, if anything's going to be soft, it's going to be the internal bone volume. So sometimes I say wait 5 or 6 months, wait a little longer on a case with a larger defect. But inevitably, always, that defect of the buccal is going to look beautiful even before the internal bone has healed. So that's a great technique. Finally, I like to talk about the maxilla, the posterior maxilla. Well, what could go wrong in the posterior maxilla? We extract the tooth, we put bone in. Well, what do we see sometimes? And again, maybe this is in my office. I sometimes make note of my complications over anybody else's, the things that have frustrated me. There have been times we do this very standard, straightforward graft. We bring the patient back in. I always bring my patients back in about 4 months for a pre-implant check, just to evaluate the bone, take a CBCT. Well, sometimes we go back in on these maxillary molar cases, and I say to my assistant, I said, where'd my bone go? Or my assistant's looking at me and she's saying, okay, what size implant? We going that 4/8 by 10? We going a 5 by 10? What are we doing? And I look at her and I say, yeah, we got to discuss this. We got to pivot here. I know people can use Versa drills and do some amazing things, and that's great. But even in a case like this, I tend to be a little conservative with that. So I might go in and have to do a lateral augmentation here at the time of implant placement. Maybe I can get away with a Versa technique in some of these cases. But we've had sinus expansion down into the apical space, and we've had a loss of vertical dimension. Well, what we've learned through the studies back in 2018, a couple of researchers did a study. We know that the pre-root condition, the pre-root orientation can dictate how much variation we're going to get in these cases. So if I've got bone barrier from the apices of the roots to the sinus floor, I'm pretty much smooth sailing. I'm not going to have really many issues with that. If I do have the roots contacting the sinus, I might get a little more resorption. You have to understand, I've got bundle bone lining those sockets. I've got no bone beyond that side, the Schneiderian membrane. So I might have more resorptive activity, more osteoclastic activity in those zones. Now, when I start to get to a point that I have a partial protrusion of the palatal root, or even a complete protrusion of the roots into the socket, I know I'm going to expect now. I know now. I've come to many of these cases and banged my head in the wall saying, what happened? But I know now when I see this, especially that complete protrusion, I know there's going to be a strong resorptive process there, and I can expect that I'm going to have some thin bone in that area. Also in the maxillary posterior, I want you guys to understand that when things go wrong, when we don't line a defect correctly, when we don't manage a case correctly, or if there's a large infection up there, we don't manage that infection conservatively and effectively, resorption is like a wildfire. It's not contained. It propagates like a wildfire. And sometimes we can see such destruction quite actively in these cases. You see this case here that was sent to us after the extraction. It was sent to us once we had the situation on the right from a surgeon about an hour away. And we can see what we have here, a very basic situation that could have been managed at the time of extraction. But if there's any mismanagement on these maxillary posterior cases, things can go south very quickly. So you see, this is a case that we now have to manage. And sometimes we iatrogenically cause these issues, and maybe it's just me, but sometimes we have these cases, maybe there's not a lot of interproximal bone And we know that upper molars can be stubborn to get out. We sometimes have to section quite a bit to get these roots out individually. Well, what if there's not a lot of interproximal bone? We don't have a lot of space. Have you ever exposed the root structure of that interproximal, of the tooth adjacent, or is it just me? Well, sometimes I have. And when we expose that root structure, we know that's going to be harder to build the bone onto. So when we talk about what can we do, as I close here, what can we do to mitigate against these issues? We took maxillary molars, we took 42 maxillary molar sockets, and we tried to add some advantages to us to avoid this sort of collapse. We did three things. We either did autogenous bone chips to mix into the graft so that we can accelerate the bone growth process just to speed up versus the resorptive process. Sometimes we used a PDGF in these cases, same concept, to act as an accelerator of bone growth. And sometimes we mixed a xenograft with an allograft, or sometimes I even packed a xenograft at the apical portion where it was mostly bundle bone in the sinus, in the protruding area, I should say, to try to create a little more form stability. That xenograft we know is going to resorb much slower versus the allograft is going to hold its form a little more. And in these cases, we saw that out of 40 out of 42 cases, we maintained the vertical bone volume within 1 millimeter of the grafted amount that we had placed. So sometimes in these upper molars, you have to think, okay, this is going to collapse on me. What can I do to mitigate against that collapse? You can see here, we've managed this same with that same defect technique, really nothing fancy here. I didn't have to do a large vertical augmentation here. I placed the RTM at the lingual, placed the PTFE, used some autogenous bone in this case, and you can see we still had to do a little vertical sinus lift, but that's much better than the scenario that this patient was in previously. So when we go to socket grafting, ridge preservation, or as I like to call it, alveolar ridge formation, okay? When I see that, or a guided bone formation even, we can call it. But when we see these situations, don't go into it just assuming I'm going to use bone and a collagen plug and be done. Every time I'm going to use bone and a piece of collagen. I want you to go in and understand that there are variations, there are choices, there are issues that can cause curveballs to be thrown at us. So go in, assess the situation, see what you have. Look at the pre-root position. Look at the situation you have going in. Look at the volume of the palatal bone and the facial bone. See what you're going into so you know how to address it. Have your armamentarium ready for you for a bunch of different options. Go ahead and accelerate the bone, especially when we have these stubborn cases. Use an accelerator, use autogenous bone, get comfortable harvesting autogenous bone. Even if you're really not too deep in your surgical journey, understand your anatomy first, and then understand some conservative techniques to harvest some autogenous bone to mix through the graft. A PDGF, also PRF, if that's something that's easier for you to take, but anything to accelerate the bone. Containment, use membranes in a smart way. Contain everything you place, contain bone, whether you're doing large augmentations like I showed you or basic ridge preservation, have proper containment that makes sense. And finally, the easiest thing you can do is in cases where you think you've got a curveball, maybe it's a case with a defect, maybe it's just a wide socket with no interradicular bone, maybe it's one of these upper molar sites, maybe it's a diabetic patient. Give it more time to mature. Not all cases are 4 months and we go in, 4 months and we go in. Sometimes I wait 6 months. Sometimes I wait 7 months just to really give the bone a chance to mature so that when I go in, I'm not in a compromised situation. I always like to say, you're not placing grafts, you're defining whether implants succeed or just survive. And that's really important to me because we are not after the quote 97% implant survival rate. I am after an implant success rate. And we know that a lot of the periimplantitis and failure cases we have, Boozer's doing some great studies on this with a large group of great clinicians, identifying that most complications of periimplantitis is caused by the surgeon themselves. So please be responsible. Please use great biomaterials. Here's my information. Don't hesitate to email me for any questions. Follow me on Instagram there. And I thank you for your time. We got our moderator here, probably some time for a few questions.
Hey, Dr. Wardany, thank you so much. That was really great info. Now it is time for the Q&A portion. We've got a few that have come in. Just a reminder, there's a Q&A button up there on the right-hand side of your screen. So if you hit that, you can send some questions in, but we've got a couple already. Back to your allograft of choice. I know you said use the 70-30 for most of your ridge preservation cases. Are there any other indications or times that come up that you use a different mixture? And then what indications are those?
That is really my mixture. I can't say that in the past I've used different bone compositions. I've definitely used different bone compositions, but different companies. But really, over the last 6-7 years, it's been a 70-30 mineralized, demineralized mix. And like I said, I am not a university researcher. I don't have a histology lab in my office. So I go by the UT San Antonio Brian Mealy studies that really are quite extensive. And so, yeah, I stick with the 70-30 mix with the allograft, but then there are indications where I would use a xenograft with or alternately to an allograft.
Right. Okay. Yeah. And that kind of leads into the next one. Why is your preference to use xenograft in the gap?
That's my preference. Now, you can use an allograft in the gap. That is just simply my preference. I believe in the biology of a xenograft holding its form in that situation, but you can absolutely use an allograft in the gap. And typically with an allograft or even a xenograft, like I said, I'm very conservative. I'll do anything I can to get biology on my side. I take immediate implants very seriously. Even with that, if I'm going to use a xenograft, and I have used allograft before, but I do still like to take some autogenous shavings and mix that in those cases. But you could use an allograft.
And that the shavings, that's when you were using the micros to get some of those shavings and then put them back in the socket.
Okay. Yeah, and especially in a gap situation where, if I'm doing a very large augmentation, I'm definitely going to use a safe scraper. I might use 1, 2, or 3 safe scrapers to get a large volume. But if I'm just taking some bone for an anterior single case, that micros scraper is just smaller, easier to use, very easy.
Okay. Back to the socket defects. Is a pericardium an alternative that you've ever used to the cross-linked, and why do you like the cross-linked?
You can use other membranes. I've just found that the cross-link membrane, the whole basis of cross-linking is that it's going to extend the resorption time. So whereas a native collagen membrane is going to have a much shorter, native collagen membranes have their benefits. They're going to allow for vasculature transmission through the membrane into the graft. So it definitely has its benefit. But when I have a defect, my focus is just to contain. My focus is simply to make a barrier. And a cross-linked membrane, the advantages of cross-linked membranes is it's going to resorb slower. It's going to disappear and resorb slower. So I like the cross-linked membrane for that reason. Are there other membranes I've used in defect management? Absolutely. But I've just seen the most predictable and consistent results using that membrane for my defect management. And I just want to say there are techniques and other materials you can use and get decent results. These are the techniques that I've used that have been most predictable for me.
Okay. How do you treat a socket that has little to no buccal wall, like missing half or the entire buccal wall? This person's saying there's a majority of cases that he encounters with perio or endo infections. In this case, do you layer the RTM with the PTFE, or is there another method or technique you like?
I think that's whoever asked that's an excellent question. When we have a very large defect, a buccal wall is completely gone, or a periodontally involved defect. First of all, when it's a perio issue, we're going to extract and manage perio first, and then we will come back in and do an augmentation after the perio is controlled. So we are not rushing in any perio case, no matter what technique you do. If it's a perio compromised case, we need to manage the perio first 100%. Secondly, if I do have those types of cases, more large advanced cases, I will not place a socket graft ridge preservation on that day. I will extract, wait about 6 weeks, and then come back in. And my mind is already planning on a large augmentation. I'm in augmentation mode in that realm. So as long as I've got the interproximal bone peaks that are on my side still and still working with me. But that's a great question. If I've lost complete buccal wall apically, I'm just going to close up, take the tooth out, close up, let the soft tissue heal, let the soft tissue quality improve. And now I'm going into augmentation mode, a GBR mode.
Okay. Sometimes the 12 by 24 may not be long enough on the DPTFE membranes. Do you recommend using a 12 by 30, the longer one, or is it okay to layer the PTFE membranes and maybe stack two?
No. I was asked that question before at the symposium, actually. No, I use the long one. Yeah, and I should say that's a great question. For molars, I always order the long ones. For my molar sockets, I always use the long one. Hands down. There are times I might have to trim it a little short, but I 100% on molars use the long size. Great question.
When you're choosing between DPTFE and like the collagen matrix, Z-derm, or something else, how do you choose between those two? And then is there a place that you've ever used a synthetic bone plug?
I haven't used the bone plugs. I know bone plugs are becoming a little more popular now. Like I said in the beginning of this webinar, I tend to stay with what's worked for me for years. If something's worked, I maintain that, and I go with what's been also researched and published the most. There is research on some of these bone plugs that's starting to come out, and more power to those who are using it more often. I think the bone plugs are great for wisdom teeth extractions. Sometimes I think they're a great indication if a patient's not planning on doing implants at all, where we can put something simple like that, maybe not have to use a membrane. I think those are indications there. But really, I've stuck with PTFE and then collagen over the years.
Okay. Back to the immediate implants. For an immediate anterior implant with a really thin facial plate, is a tunnel facial to the plate and graft without a membrane reliable?
Good. Good questions today. Good questions today, Eric. It's been tried. I would not call it predictable and reliable. I have done that in my past, and typically in those cases, I will tunnel in xenograft with PDGF growth factor and use the periosteal blood supply, the periosteal growth factors in synergy with the PDGF. If it's a very small amount of augmentation that I need, I don't think it's a bad technique. I've used a technique that is a little more technique sensitive, where I do that tunnel, but I still get a layer of collagen against the periosteum. I feel better having some form of a collagen there. Like I said, a little more technique sensitive to get that collagen layer in. But sometimes if I don't need too much augmentation, I can tunnel that in through. But I tend to still put a collagen membrane up against the periosteum there. So it's a technique that's been tried, and I think there's some published articles on it, but it wouldn't be my go-to. And I should say, when we talk about immediate implants and the benefits of immediate implants versus early implant placement, where I'm going to lay a flap and really augment some bone, the studies have shown, Boozer's done a lot of studies on this that's shown that when we talk about maintaining papilla, does placing a flapless immediate implant on its own compared to early implant placement where I've laid a flap maintain the papilla more so? No, studies have shown that they're about the same. Now, with that said, if I immediately provisionalize, or if I do a socket shield type of procedure, that can maintain the papilla. Okay, but just simply comparing flapless immediate implant versus early implant placement, long-term studies by Boozer and Chen have showed that that papilla is not preserved one way or the other.
Okay. Well, that was a great answer and great information there. I think with that, we will call it a night on this. I just want to thank everyone for watching. Hope you enjoyed the webinar. Remember, there's going to be a feedback survey that's going to come out to you shortly. Once you complete the survey, then you'll get your CE certificate. So, Dr. Wardany, thank you so much for your time. It's been a great session, very informative, and yeah, we're excited with this. And thank you so much for all the information.
Appreciate you
Goodbye,
having
everyone.
me. Had a great time. Take care, everybody. Bye bye.